Hi everyone. On today's podcast, we're going to talk about the research evidence on external cephalic version for breech-positioned babies. Welcome to the Evidence-Based Birth Podcast. My name is Rebecca Decker, and I'm a nurse with my PhD and the founder of Evidence-Based Birth. Join me each week as we work together to get evidence-based information into the hands of families and professionals around the world. As a reminder, this information is not medical advice. See ebbirth.com/disclaimer for more details. Hi everyone, and welcome to today's episode of the Evidence-Based Birth Podcast. Before we get started with our research information, I have one quick announcement. We recently just wrapped up our 20% off sale on the Evidence-Based Birth Professional membership. However, we've decided to extend that sale for 24 more hours. So if you missed the cutoff last night, and you are listening to this on April 21st of 2021, you can still get that discount on the Evidence-Based Birth Professional membership by going to ebbirth.com/membership, as long as you sign up by tomorrow morning, 8 a.m. on April 22. If you have any questions, you can always feel free to reach out to our team at info@evidencebasedbirth.com. And with that, let's get to our topic for the day. So today we are wrapping up a mini series all about breech-positioned babies. In episode 171, we talked with Janae and Andrew Rick about their vaginal breech birth story. And in episode 172, we talked with Dr. Rick Cephalic and Dr. David Hayes of Breech Without Borders about the evidence on planning a vaginal breech birth. Today we're going to wrap up our series by talking about the research evidence on external cephalic version for breech-positioned babies. Just a quick content warning before we get started. I will talk briefly about research statistics on stillbirth and infant mortality when we talk about the research evidence on ECV. I originally published an article on this topic in 2012, and we've been in the process of updating it in the spring of 2021. You can find all of the references and more details about this information by going to evidencebasedbirth.com/breech version. That's all one word, breech version. So how common is the breech position for babies? Well, the breech position, or the baby's bottom presenting first, is present in about 3 to 4% of term pregnancies. Breech positioning is more common prior to term. 25% of babies are breech before 28 weeks, but by 32 weeks of pregnancy, only 7% of babies are breech. The vast majority of breech babies born in the United States, as well as around the world, are now born by planned cesarean. Although we talked about planning a vaginal birth with the breech baby in the last episode, today I want to talk about the use of a safe procedure that can help turn babies into a head-down position, otherwise known as the cephalic position, which may help lower the cesarean rate in places where breech vaginal birth is not supported. So what is an external cephalic version? Well, it literally means external from the outside, cephalic head first, and version turning. An external cephalic version, or ECV, is when a care provider puts their hands on the outside of your belly and turns the baby, using either a forward or backward roll, into a vertex or head down position. This is also called an ECV, a version, or a hands to belly procedure. For our update of our signature article on this topic, we requested some new statistics from the Centers for Disease Control in the United States. We found that in 2019, there were more than 150,000 breech babies born that year in the United States, or about 4% of all babies. Of these breech-positioned babies, 93.8% were born by cesarean, and the number of known breech births made up 11.8% of all cesareans in the United States in the year 2019. This means that only about 6% of breech-positioned babies are born vaginally in the United States. The vast majority are born by cesarean. An ECV may be a safe way for people to turn their babies into a head-first or cephalic or vertex position and avoid a cesarean in places where planned vaginal breech births are not supported. When we contacted the CDC, they gave us the most recent data in the US for how many people have an external cephalic version. The numbers are shockingly low. In 2019, only about 10,783 people underwent an ECV procedure, which was down from 11,158 in the year 2016. The success rate of ECV procedures also decreased in 2019. It was 48.5% compared to 55.8% success rate in 2016. Of those people who had successful ECVs in 2019, 71.9% went on to have spontaneous vaginal births without the help of forceps or vacuum. On the other hand, the 2019 failure rate of ECVs was 51.5%, and 91.3% of people with failed ECVs went on to have cesarean births. There's general agreement that, in the United States at least, the cesarean rate is higher than necessary, and that changes should be made to safely bring it down. For this reason, there's been renewed interest in both ECV and planned vaginal breech birth. As the rate of successful ECVs and vaginal breech birth goes up, the cesarean rate goes down. Unfortunately, the ECV is an underused procedure. In their 2020 update of their guidelines on ECV, ACOG, the American Congress of Obstetricians and Gynecologists, stated that as many as 20 to 30% of people who are eligible for an ECV are not offered it, even though attempting ECV is an evidence-based way to lower your chance of cesarean. A similar situation takes place in Australia. In 2017, an Australian study by Bin et al. Looked at more than 32,000 people who were pregnant with a breech baby at term between the years 2002 and 2012. Only 10% of the group attempted an ECV, and as many as 67% did not attempt an ECV, even though they were considered to be good candidates for the procedure according to Australian practice guidelines. The authors were not sure whether the low rate of ECV attempts in Australia is related to care providers failing to offer it or pregnant people declining the procedure. In the US, it could be that care providers are not offering ECVs as readily because health insurance plans consider an ECV to be part of regular routine prenatal care, thus preventing hospitals and clinics from being adequately reimbursed for an ECV. An ECV is not necessarily a regular routine thing. It takes time and resources, especially considering the potential need for medications and the need for pre- and post-procedure tests and monitoring. So are ECVs effective for lowering the risk of cesarean? Well, since breech babies are almost always born by cesarean, there has been an interest in attempting ECVs to increase the chance of vaginal birth, and because ECVs are cost-effective when compared to scheduling a cesarean. We have two major systematic reviews on this topic. The first one was published in 2015 in a Cochrane review by Hofmeier et al. They combined the results from 8 randomized controlled trials with about 1,300 participants who were randomly assigned to either an ECV or no treatment. The quality of the studies was mixed. In order to control for lower quality of some of the studies, the researchers looked at the results both with and without the poorer quality studies. When they did so, the results stayed the same. Overall, the Hofmeier et al. Review found that attempting an ECV at term decreased the relative risk of breech birth by 58% and decreased the relative risk of cesarean by 43%. There were no differences in any other outcomes, including APGAR scores, neonatal admission, or infant deaths. The studies did not look at maternal satisfaction. However, it's important to note that 5 of the 8 studies in this review took place in the 1980s, a time when breech vaginal birth was slightly more common. Since the publication of the term breech trial in the year 2000, which we talked about at length in episode 172 of the Evidence-Based Birth Podcast, breech vaginal births have become extremely rare, and most breech babies today are born by planned cesarean. Therefore, it's possible that if these randomized trials were repeated today, having an ECV might result in an even larger reduction in the risk of cesarean. In another systematic review published in the year 2020, Devold Pei et al. Reviewed 2 randomized trials conducted in 1981 and 1984, and 7 observational studies carried out between 1985 and 2014, comparing the effects of ECV or no ECV on more than 184,000 pregnant people who were eligible for an ECV at 36 weeks or greater. Altogether, the review included about 7,000 attempted ECVs. These studies came from high-resource settings from Europe, the US, Canada, Australia, and New Zealand. When the review authors combined the data, they found that an attempted ECV was linked to a significant reduction in cesarean rates. They estimated that a policy of attempted ECV compared to not attempting ECVs would probably result in 320 to 710 fewer non-cephalic presentations at birth and 271 to 376 fewer cesareans per 1,000 labors. The authors did find that ECV attempts were linked to a slightly increased rate of APGAR scores of less than 7 at 5 minutes compared to no ECV attempts, 24 versus 19 per 1,000. Attempted ECV had no effect on low APGAR scores at 1 minute, stillbirth or infant death, or NICU admissions. Although this review did look like it covered a large amount of births, it was limited by an unclear risk of bias for the 2 randomized trials and a serious risk of bias for the 7 observational studies. The largest study in this review made up 183,000 out of about the 185,000 pregnancies, and this really large study had serious risk of bias, largely due to its reliance on U.S. birth certificate data from 2006. And this data from U.S. birth certificates is known to not be very reliable. The review authors concluded that more high-quality research is needed, but the available evidence suggests that when ECV is attempted at or near term, there is a substantially reduced risk of cesarean and a slightly increased risk of lower APGAR scores at 5 minutes. A separate observational study published in 2016 by Weiniger et al. Found several additional benefits to ECV. This study examined data from a U.S. healthcare utilization database and was not included in either the Cochrane review or the Devold-Pay et al. Review. Weiniger et al. Compared 56,409 people who had a successful ECV with more than 1 million people who had a persistent breech baby at the time of birth. The cesarean rate was only 20% in the successful ECV group versus 95% in the persistent breech group. The researchers also found that people with successful ECV also had better overall maternal outcomes, including lower rates of infection, shorter hospital stays, and lower hospital charges, but higher rates of inflammation of the membranes. Overall, it's thought that a successful ECV can have important personal benefits for an individual by helping them avoid major abdominal surgery. ECVs can also have population-level benefits by lowering the overall cesarean rate. If everyone with a breech baby at term who was eligible attempted aversion, then about half would be successful. Of those with successful ECVs, about 3/4 would eventually give birth vaginally. This means that more than a third of people with term breech pregnancies could avoid a cesarean if all of them attempted aversion. Given that 3 to 4% of all term pregnancies are breech, the overall cesarean rate would come down by 1 to 2%. Obviously, not all people with breech pregnancies at term are good candidates for the procedure, and some would refuse the procedure. So the real reduction in the cesarean rate may not be as large as that. But it's important to understand that the real benefit in reducing the number of cesareans from breech pregnancies comes later on, in subsequent pregnancies. Since many of those people who have a planned vaginal cesarean birth with a breech baby would then have repeat cesareans down the road, which carry additional risks. So we've talked about the major benefit of an ECV, which is that it substantially lowers the risk of cesarean. And we talked about the one study that found a slightly higher risk of low APGAR scores of less than 7 at 5 minutes. Well, are there any other risks of an ECV seen in the evidence? In order to look at more rare risks, we need to look at a study that has a larger number of ECV procedures. In 2008, Groot-Skolton et al. Combined the results of 84 studies that included nearly 13,000 participants who experienced an attempted ECV. The researchers only included studies that reported on complications from attempted versions on singleton babies done after 36 weeks of pregnancy. The average success rate for turning a baby out of the breech position was 58%. The overall complication rate was 6%, and the rate of serious complications, such as placenta abruption and/or stillbirth, was 0.24%. There were 12 stillbirths out of 12,955 attempted versions, and 2 of these deaths were related to the version. The other 10 deaths were unrelated to the external version or unexplained. The unexplained stillbirths were diagnosed anywhere from 10 to 31 days after the ECV. Placental abruption occurred in 0.18% of participants. There were 11 placental abruptions out of nearly 13,000 versions, and 10 of these abruptions resulted in an emergency cesarean. Other complications included cord prolapse, 0.18%, temporary abnormal fetal heart rate patterns, 4.7%, vaginal bleeding, 0.34%, and the waters breaking, 0.22%. There was one urgent cesarean for every 286 ECV procedures. In summary, the researchers found that ECV is safe, but they recommended that an ECV should take place in a setting where an urgent cesarean could be performed if necessary. So although ECVs can lower the risk of cesarean and they appear to be safe, the potential pain or discomfort from an ECV may discourage some people from attempting the procedure. Several studies have asked people about their experiences during and after attempted ECVs. There was one study published in the Netherlands by Truigens et al. In 2014. They looked at 249 people who were going to have an ECV. And right beforehand, they spent about 30 minutes interviewing people about symptoms of depression and fear of the procedure. Immediately after the procedure, a different researcher who was blinded to the earlier interview assessed each participant's pain perception. They found that the most important factor influencing pain perception was whether or not the ECV was successful at turning the baby. To put it another way, people who had successful ECVs reported significantly less pain than people with failed version attempts. The average ECV attempt lasted just under 4 minutes and ranged from less than a minute to 16 minutes. As would be expected, people who underwent longer procedures reported more pain. The important takeaway from this study, however, was that the length of the procedure, or any other factor for that matter, didn't totally explain why people with failed ECV attempts reported more pain. It appears that negative emotions that follow a disappointing outcome influence how much pain you recall. Data from the pre-ECV interviews showed that depression and fear also independently influenced pain perception. This means that people who had signs of depression or expected the procedure to be painful were more likely to actually find it painful, compared to people who did not have signs of depression or fear going into the procedure. In Australia, Watts et al. Interviewed 16 first-time mothers and 6 experienced mothers who attempted an ECV, but it did not successfully turn the baby. About half the mothers went on to have planned cesareans and the other half had planned vaginal breech births. When asked how they felt about the attempted ECV, the majority replied that the procedure was painful, and some reported pain that lasted for a while after they were home. Nearly half of the people interviewed said that they would not attempt an ECV in a future pregnancy. But it's important to remember that the people in this study did not have successful ECVs. And as we saw in the study from the Netherlands, whether or not the ECV turns the baby can greatly influence your pain perception. The authors from this study concluded that attempting an ECV should be only one of multiple options that pregnant people with term breech can consider. Other options may include a planned cesarean or planning a vaginal breech birth. If you want to learn more about vaginal breech birth, we highly recommend you visit breechwithoutborders.org. They have all the research evidence and tons of resources about planned vaginal breech birth. You can also listen to our interview with the founders of Breech Without Borders at Evidence-Based Birth Podcast, episode 172. In terms of the option of planning a cesarean for a breech baby, we have a signature article about planned and unplanned cesareans and how you can make them family-friendly. To learn more about family-friendly cesareans, visit our signature article at ebbirth.com/cesarean-care. That's all one word, ebbirth.com/cesarean-care. Okay, so moving on, let's talk about pain management during an ECV. Although an ECV can be painful, there are therapies that can be used to reduce the discomfort of the procedure. One study in Spain compared 300 people who received nitrous oxide or laughing gas starting 3 minutes before attempting the ECV, with 150 people who did not receive gas with the procedure. This study was carried out by Burgos et al. In 2013. They found no differences in the rate of complications, the overall cesarean rate, or the success rate of the ECV. But people who received nitrous oxide were about 50% less likely to report severe pain from the procedure. Another study published by Wang et al. In 2017 from China randomly assigned 72 people to IV opioids and 72 people to a saline placebo IV during an attempted ECV. The particular IV opioid that they used was remifentanil. They found that the people who received the remifentanil reported less pain immediately after the procedure and more satisfaction 10 minutes afterwards. They also found a difference in the success rate of the version between the two groups. The people who received remifentanil had a success rate of 57%, and the placebo group had a success rate of 39%. There were no differences as far as complications. A review paper by Magro Meloso et al. In 2016 found that people who receive epidurals, spinals, or a combination of both report less pain and discomfort during an ECV than those who do not. An additional benefit to epidurals and spinals is that researchers have found that these methods increase the success rate of the ECV, which I'll discuss more in a minute. It's thought that epidurals and spinals help keep your abdominal muscles relaxed, which may allow the care provider to more easily rotate the baby. So when is the best time to have an ECV? Well, you can choose to have an ECV before term at 34 to 37 weeks, at term, which is after 37 weeks, or even during labor. In the largest randomized controlled trial to compare ECVs before term and at term, researchers found that doing an ECV before term increases the chance that the baby will be head first at birth, 59% versus 51%. However, they also found that having an early ECV does not lower the risk of having a cesarean compared to having a term ECV. There was also evidence that doing an ECV before term may increase the risk of a preterm birth. In a later analysis of the data, the researchers found that lower gestational age was a predictor of success during an ECV among people who had given birth before, but that a more important predictor of success was if the baby was still floating above the pelvis or had not yet descended into the pelvis. This study was carried out by Hutton et al. In 2017. A Cochrane review from 2015 combined 5 trials to study ECVs attempted before term. The review was dominated by the large Hutton trial that took place in 2011. So not surprisingly, the results were consistent with a study I mentioned earlier. The Cochrane reviewers concluded that an ECV done between 34 and 36 weeks does result in more babies that are head down at the time of birth, compared with Aversion at gestational age of 37 weeks or greater. However, the decrease in breech presentation at birth did not lead to an overall lowering of the cesarean rate. Based on these findings, the first attempt at an ECV is usually scheduled at gestational age of 37 weeks or later. People should discuss the potential benefits and risks of an early ECV with their care provider, weighing the greater likelihood of success before 37 weeks against the rare complication of birthing a preterm infant. Finally, for people who discover that they are pregnant with a breech baby during labor, there is some evidence showing that ECV can be successful when performed during early labor. In a study that used U.S. data from 1998 to 2011, the ECV success rate was 65% when it was attempted during hospital admission for birth. People with successful ECV in early labor were significantly less likely to have a cesarean or to have a hospital stay greater than 7 days, compared to people who remained with a breech presentation at the time of birth. What does the research say about techniques that increase the likelihood of a successful ECV? Researchers have studied several techniques that could increase the chance of success. So far, the most helpful technique seems to be using drugs to prevent labor contractions, also known as tocolysis. In a Cochrane review, researchers combined the results of 28 studies with more than 2,700 participants who were randomly assigned to receive an ECV alone or an ECV with an additional technique such as tocolysis or having an epidural. The participants who were randomly assigned to receive tocolytic drugs to prevent contractions during the version were 23% less likely to have an eventual cesarean for breech positioning compared to those who did not receive tocolysis. Participants who received tocolytic drugs were also 68% more likely to have babies with head-first positioning at the start of labor. In the Cochrane review, the participants who were randomly assigned to have an epidural or spinal in combination with the tocolytic drugs during the ECV were 39% more likely to have a successful version. There were no differences in any of the other outcomes between participants with and without epidurals, such as cephalic presentation at the start of labor or the rate of cesareans. But the number of people in the study, 279 people, might not have been large enough to find an effect. So that data came from the Cochrane review published by Kluver et al. In 2015. A slightly more recent meta-analysis by Magro-Malasso et al. In 2016 combined 9 randomized trials with 934 people to look at the effect of epidurals and spinals on outcomes after ECV. They found that the participants who received an epidural, spinal, or combination spinal epidural had a higher rate of successful ECV compared to the participants who received IV pain medications or no treatment, 58% versus 43%. The epidural spinal group also had a higher rate of cephalic presentation at the start of labor, 55% versus 40%, and a higher vaginal birth rate, 54% versus 45%. People in both groups also received tocolytic drugs. There were no differences in the rate of complications between groups. Although it seems that epidurals and spinals make it more likely that the ECV will be successful, some care providers recommend against epidurals and spinals for ECV attempts because it makes for a much more longer and more complicated procedure as well as more expensive procedure. One small study found that vibroacoustic stimulation, or applying sound to your abdomen, resulted in successful ECVs in 86% of participants, compared to 8% of participants in the placebo group that only received sound directed into the nurse's arm. This current evidence is too weak. The study was very small, with only about 34 people, to draw conclusions about the effectiveness of this technique. However, it looked promising, and so it deserves further research in larger studies, especially since vibroacoustic stimulation is inexpensive, non-invasive, and has no known side effects. So are there any other factors that may influence the ECV success rate? We corresponded with a physician reviewer who found in his experience that there are 3 important factors for a successful ECV procedure. Number 1, a physician who believes in the benefits of the procedure and is skilled at performing it. Number 2, a well-informed patient who is motivated to avoid a first and subsequent cesareans. Number 3, a willingness by the physician to abandon the procedure if it requires more than the normal amount of manipulation or if the baby does not tolerate the procedure. Interestingly, one U.S. study found an inverse relationship between the rate of successful ECV and a hospital cesarean rate. In other words, the higher the cesarean rate at the hospital, the lower their ECV success rate. This study was published by Weiniger et al. In 2016. It's not clear why this is the case. Perhaps hospitals with high cesarean rates are not following best practices for ECV success, or perhaps this relationship has to do with the type of patients who are seeking care at hospitals with high cesarean rates. Researchers have also looked at factors specific to the individual and the pregnancy that may influence the success rate of versions. The researchers that conducted the randomized trial comparing early versus late ECV used data from that trial and from an earlier pilot trial to study the factors that influence the success rate of ECVs. In the Hutton et al. Study published in 2017, of the 1,253 people who had an ECV, 742 were giving birth for the first time and 511 were giving birth to a subsequent baby. The ECV was considered to be successful, meaning that the baby immediately turned and was still in head-first position at the time of birth, and 33% of people giving birth for the first time and 61% of those who had given birth before. Overall, 11% of the participants attempted more than one version. However, it's not really standard practice in the United States to attempt another version on a later day after a failed version happens first. The researchers also found that the following factors are strongly linked to higher ECV success rates. Having given birth to previous children, the baby is not yet engaged in the pelvis, described as floating or dipping, and the care provider can easily feel the baby's head on palpation. This is related to the baby's position as well as maternal body fat percentage. Other factors that increase the likelihood of an ECV success to a lesser extent are if the placenta is posterior on the backside of the uterus, if your BMI is less than 32.7, if there are normal levels of amniotic fluid, if the waters are intact, if the uterus is normally shaped, the abdominal wall muscles are relaxed, and the baby's in a non-frank breech presentation. Another way to look at it is that certain factors also make aversion more likely to fail. People should have an honest discussion with their care provider before deciding to attempt an ECV. If you have one or more factors that decrease the likelihood of success, then you should know that you have a lower chance of success, not to be discouraged, but to have realistic expectations about the outcome. This is not a complete list, but some factors that may decrease the success rate of aversion include giving birth for the first time, the baby is already engaged in the pelvis, the care provider cannot easily feel the baby's head on palpation, your body mass index is 32.7 or higher, the baby is small for gestational age, the placenta is on the front, side, or top of the uterus, the amniotic fluid volume is higher or lower than normal, your abdominal muscles or your uterus are firm and tense, your waters have already broken, the baby's spine is located toward the back, and frank breech presentation. As I said earlier, researchers have also found that a gestational age of less than 37 weeks is linked with successful ECVs in people who have given birth before. However, researchers recommend that care providers focus on the individual baby's descent rather than using a standard gestational age cutoff, so that an ECV can be planned before the baby becomes firmly engaged in the pelvis, while still doing as much as possible to avoid influencing a preterm birth. Are there any reasons why you could not have an ECV? Different guidelines list different reasons why certain people should not have an ECV. Whenever there is a reason clinically not to do something, that reason is called a contraindication. In 2012, Rosman et al. Did a systematic review to determine which contraindications for ECV are based on scientific evidence. Now, I want to make sure you know that the failure to find research evidence does not mean that that factor is safe and not a contraindication. Rather, it just simply means there is a lack of evidence. We can't say that the factor should be contraindicated, but we also can't say that it should not. For 39 different contraindications for ECV listed in international guidelines, the researchers could only find research evidence for 6 of the 39. 33 of the 39 contraindications for ECV were based on clinical opinion alone. Of the 6 contraindications that had research evidence, 5 of these lacked strong evidence that they were in fact contraindications. The research evidence does not support using these as contraindications for an ECV. Having had a prior cesarean, fetal growth restriction, suspected big baby, low amniotic fluid, and high amniotic fluid. The authors concluded that there is good evidence based on both research and physiology that people should not have an ECV if they have a history of placental abruption or if placental abruption is suspected, if there is a diagnosis of severe preeclampsia, or if there are signs of fetal distress. Also, if vaginal birth is considered to be contraindicated, then an ECV would also be contraindicated. Again, it is important to note that although there may be little research evidence to back up some contraindications, many factors haven't been well studied, with the exception of prior cesarean, which I'll talk about in a minute. And some care providers may use their expert opinion to recommend against an ECV in certain circumstances. A care provider may anticipate a difficult version, a low likelihood of success, or perhaps that the benefits do not outweigh the risks. For example, a care provider may not want to perform a version on someone with very low amniotic fluid because that increases the difficulty of the procedure. Other care providers might not want to perform an ECV if the baby has the umbilical cord wrapped around the neck. Although there is no solid research on these topics, the care provider may base their clinical opinion on prior experience or the mechanism by which the factor could affect the ECV procedure and find it to be too difficult or that the risks outweigh the benefits. ACOG recommends that, quote, because the risk of an adverse event occurring as a result of ECV is small, and the cesarean delivery rate is significantly lower among women who have undergone successful ECV, all women who are near term with breech presentations should be offered an ECV attempt if there are no contraindications, end quote. Since the data have yet to establish clear contraindications, they recommend that care providers consider each patient individually as a potential candidate. The expert medical opinion is that care providers should assess contractions and fetal well-being before and after the attempt, and that an ECV should only be attempted in settings where cesareans are immediately available. ACOG also recently updated their guidelines in 2020 to recommend consideration of the use of epidurals or spinals in combination with tocolytic medications to increase the ECV success rate. People with this combination treatment had a higher rate of successful ECV, were more likely to have a head-down baby in labor, and have a higher chance of vaginal delivery after a successful ECV. So, can someone with a prior cesarean have an ECV? Often we get contacted at EBB by people who want to attempt a VBAC, but their baby is in a breech position and their provider is refusing to perform an ECV. So what does the research say on this subject? A 2017 Australian study of more than 32,000 people with breech pregnancies found that a prior cesarean was the most common reason that people were told they were too high risk to attempt an ECV. This was published by Ben et al. In 2017. However, as I already mentioned, there is little research evidence showing that a prior cesarean should be considered a contraindication. In fact, the research evidence that we do have suggests that the benefits and risks of an ECV are quite similar between people who've had a prior cesarean and those who have not. The most recent and largest study on this topic was a systematic review published by Homofar et al. In 2020. The authors identified 8 observational studies with more than 14,000 participants who had an ECV. About 1,200 had a prior cesarean, almost all of them having only had one prior cesarean, and more than 13,000 who did not have a prior cesarean. All of these people had an attempted ECV. In all 8 of the studies that these numbers came from were rated as being at low risk of bias. The researchers found that the median ECV success rates among people with a prior cesarean was 74%, which was similar to those who did not have a prior cesarean birth in this study. About 75% of people who had a successful ECV and a history of prior cesarean went on to have a VBAC. Researchers estimated that for every 1.7 ECVs that are attempted in people with a prior cesarean, one subsequent cesarean birth would be avoided. In terms of side effects on people with a history of prior cesarean, 7 of the 8 studies measured uterine rupture, and there were 0 cases of uterine rupture during ECV among people with or without a prior cesarean. Other rare adverse effects included temporary fetal heart rate abnormalities, 0.6%, and an urgent cesarean, 0.2%. The authors concluded that the majority of people with a prior cesarean who have a successful ECV will go on to have a VBAC. So that wraps up all of the research evidence that we were able to collect on ECV. In summary, the research evidence shows that attempting an ECV will result in a baby who is head down at the time of birth around half of the time. That risk is lower in people giving birth for the first time, about 33%, and it's higher in people who've given birth before, about 61%. Also, having a history of prior cesarean does not mean you should not be offered an ECV. The benefit and risk profile seems to be very similar to those who do not have a history of prior cesarean. One thing that discourages people from having an ECV is that it may be painful for many people, but it's less painful if the procedure is successful and if you manage your fear and anxiety beforehand, and it's also less painful if medications are used to manage pain. Tocolytic drugs that prevent labor contractions have been shown to improve the success of versions, as well as when they're combined with epidurals or spinals. However, some care providers discourage the use of epidurals or spinals because it complicates the procedure. Benefits of having an ECV include significantly decreasing your risk of cesarean and decreasing the chance that your baby will be in a breech position at birth. It also decreases your risk of needing repeat cesareans with future pregnancies. The most common risks to an ECV are a temporary change in the infant's heart rate, and serious complications requiring an urgent cesarean are rare. So that wraps up our podcast episode all about the research evidence on external cephalic version for breech position babies. If you haven't already, don't forget to check out our other episodes in this series, episode 171 with vaginal breech birth story and episode 172 about the research evidence on the term breech trial as well as planned vaginal breech birth. And you can check out our resources all about having family-centered cesareans if you choose a cesarean for a breech position baby by going to evidencebased care. Thanks for listening to this evidence with me, and I'll see you next week. Bye. Today's podcast episode was brought to you by the online workshops for birth professionals taught by evidence-based birth instructors. We have an amazing group of EBB instructors from around the world who can provide you with live, interactive, continuing education workshops that are fully online. We designed Savvy Birth Pro workshops to help birth professionals who are feeling stressed by the limitations of the healthcare system. Our instructors also teach the popular Comfort Measures for Birth Professionals and Labor and Delivery Nurses workshop. If you are a nurse or birth professional who wants instruction in massage, upright birthing positions, acupressure for pain relief, and more, you will love the Comfort Measures workshop. Visit ebbirth.com/events to find a list of upcoming online workshops.